Psychosis is a condition of the mind that results in difficulties determining what is real and what is not real. Symptoms may include delusions and hallucinations. Other symptoms may include incoherent speech and behavior that is inappropriate for the situation. There may also be sleep problems, social withdrawal, lack of motivation, and difficulties carrying out daily activities. Psychosis can have serious outcomes. Psychosis has many different causes. These include mental illness, such as schizophrenia or bipolar disorder, sleep deprivation, some medical conditions, certain medications, and drugs such as alcohol or cannabis. One type, known as postpartum psychosis, can occur after giving birth. The neurotransmitter dopamine is believed to play a role. Acute psychosis is considered primary if it results from a psychiatric condition and secondary if it is caused by a medical condition. The diagnosis of a mental health condition requires excluding other potential causes. Testing may be done to check for central nervous system diseases, toxins, or other health problems as a cause. Treatment may include antipsychotic medication, counseling, and social support. Early treatment appears to improve outcomes. Medications appear to have a moderate effect. Outcomes depend on the underlying cause. In the United States, about 3% of people develop psychosis at some point in their lives. The condition has been described since at least the 4th century BCE by Hippocrates, and possibly as early as 1500 BCE in the Egyptian Ebers Papyrus. Hallucinations. A hallucination is defined as sensory perception in the absence of external stimuli. Hallucinations are different from illusions and perceptual distortions, which are the misperception of external stimuli. Hallucinations may occur in any of the senses and take on almost any form. They may consist of simple sensations, such as lights, colors, sounds, tastes, or smells, or more detailed experiences, such as seeing and interacting with animals and people, hearing voices, and having complex tactile sensations. Hallucinations are generally characterized as being vivid and uncontrollable. Auditory hallucinations, particularly experiences of hearing voices, are the most common and often prominent feature of psychosis. Up to 15% of the general population may experience auditory hallucinations, though not all are due to psychosis. The prevalence of auditory hallucinations in patients with schizophrenia is generally put around 70%, but may go as high as 98%. Reported prevalence in bipolar disorder ranges from 11% and 68%. During the early 20th century, auditory hallucinations were second to visual hallucinations in frequency, but they are now the most common manifestation of schizophrenia, although rates vary between cultures and regions. Auditory hallucinations are most commonly intelligible voices. When voices are present, the average number has been estimated at 3. Content, like frequency, differs significantly, especially across cultures and demographics. People who experience auditory hallucinations can frequently identify the loudness, location, and origin, and may settle on identities for voices. Western cultures are associated with auditory experiences concerning religious content, frequently related to sin. Hallucinations may command a person to do something potentially dangerous when combined with delusions. Extracampine hallucinations are perceptions outside the normal sensory apparatus, such as the perception of sound through the knee. Visual extracampine hallucinations include seeing persons nearby that are not there. Visual hallucinations occur in roughly a third of people with schizophrenia, although rates as high as 55% are reported. The prevalence in bipolar disorder is around 15%. Content commonly involves animate objects, although perceptual abnormalities such as changes in lighting, shading, streaks, or lines may be seen. Visual abnormalities may conflict with proprioceptive information, and visions may include experiences such as the ground tilting. Lilliputian hallucinations are less common in schizophrenia, and are more common in various types of encephalopathy, such as peduncular hallucinosis. A visceral hallucination, also called a synesthetic hallucination, is characterized by visceral sensations in the absence of stimuli. Synesthetic hallucinations may include sensations of burning or rearrangement of internal organs. Delusions. Psychosis may include delusional beliefs. A delusion is commonly defined as an unrelenting sense of certainty maintained despite strong contradictory evidence. Delusions are context and culture dependent. A belief which inhibits critical functioning and is widely considered delusional in one population may be common and even adaptive in another, or in the same population at a later time. Since normative views may contradict available evidence, a belief need not contravene cultural standards in order to be considered delusional. Prevalence in schizophrenia is generally considered at least 90%, and around 50% in bipolar disorder. The DSM-5 characterizes certain delusions as bizarre if they are clearly implausible or are incompatible with the surrounding cultural context. The concept of bizarre delusions has many criticisms, the most prominent being judging its presence is not highly reliable even among trained individuals. A delusion may involve diverse thematic content. The most common type is a persecutory delusion, in which a person believes that an entity seeks to harm them. Others include delusions of reference, the belief that some element of one's experience represents a deliberate and specific act by or message from some other entity. Delusions of grandeur, the belief that one possesses special power or influence beyond one's actual limits. Thought broadcasting, the belief that one's thoughts are audible. And thought insertion, the belief that one's thoughts are not one's own. The subject matter of delusions seems to reflect the current culture in a particular time and location. For example, in the US, during the early 1900s, syphilis was a common topic. During the Second World War, Germany, during the Cold War, communists, and in recent years, technology has been a focus. Some psychologists, such as those who practice the open dialogue method, believe that the content of psychosis represent an underlying thought process that may, in part, be responsible for psychosis, though the accepted medical position is that psychosis is due to a brain disorder. Historically, Carl Jaspers classified psychotic delusions into primary and secondary types. Primary delusions are defined as arising suddenly and not being comprehensible in terms of normal mental processes, whereas secondary delusions are typically understood as being influenced by the person's background or current situation, e.g., ethnicity, also religious, superstitious, or political beliefs. Disorganization. Disorganization is split into disorganized speech or thinking and grossly disorganized motor behavior. Disorganized speech or thinking, also called formal thought disorder, is disorganization of thinking that is inferred from speech. Characteristics of disorganized speech include rapidly switching topics, called derailment or loose association, switching to topics that are unrelated, called tangential thinking, incomprehensible speech, called word salad or incoherence. Disorganized motor behavior includes repetitive, odd, or sometimes purposeless movement. Disorganized motor behavior rarely includes catatonia, and although it was a historically prominent symptom, it is rarely seen today. Whether this is due to historically used treatments or the lack thereof is unknown. Catatonia describes a profoundly agitated state in which the experience of reality is generally considered impaired. There are two primary manifestations of catatonic behavior. The classic presentation is a person who does not move or interact with the world in any way while awake. This type of catatonia presents with waxy flexibility. Waxy flexibility is when someone physically moves part of a catatonic person's body and the person stays in the position even if it is bizarre and otherwise non-functional, such as moving a person's arm straight up in the air and the arm staying there. The other type of catatonia is more of an outward presentation of the profoundly agitated state described above. It involves excessive and purposeless motor behavior as well as an extreme mental preoccupation that prevents an intact experience of reality. An example is someone walking very fast in circles to the exclusion of anything else with a level of mental preoccupation, meaning not focused on anything relevant to the situation, that was not typical of the person prior to the symptom onset. In both types of catatonia, there is generally no reaction to anything that happens outside of them. It is important to distinguish catatonic agitation from severe bipolar mania, although someone could have both. Negative symptoms. Negative symptoms include reduced emotional expression, decreased motivation, and reduced spontaneous speech. Afflicted individuals lack interest and spontaneity and have the inability to feel pleasure. Psychosis in adolescence. Psychosis is rare in adolescence. Young people who have psychosis may have trouble connecting to the world around them and may experience hallucinations and/or delusions. Adolescents with psychosis may also have cognitive deficits that may make it harder for the youth to socialize and work. Potential impairments include the speed of mental processing, ability to focus without getting distracted, attention span, and problems with their verbal memory. Causes. The symptoms of psychosis may be caused by serious psychiatric disorders such as schizophrenia, a number of medical illnesses, and trauma. Psychosis may also be temporary or transient and be caused by medications or substance use disorder, substance-induced psychosis. Normal states. Brief hallucinations are not uncommon in those without any psychiatric disease. Causes or triggers include falling asleep and waking, hypnagogic and hypnopompic hallucinations, which are entirely normal, bereavement, in which hallucinations of a deceased loved one are common, severe sleep deprivation, extreme stress, trauma. Traumatic life events have been linked with an elevated risk in developing psychotic symptoms. Childhood trauma has specifically been shown to be a predictor of adolescent and adult psychosis. Approximately 65% of individuals with psychotic symptoms have experienced childhood trauma, e.g., physical or sexual abuse, physical or emotional neglect. Increased individual vulnerability toward psychosis may interact with traumatic experiences, promoting an onset of future psychotic symptoms, particularly during sensitive developmental periods. Importantly, the relationship between traumatic life events and psychotic symptoms appears to be dose-dependent, in which multiple traumatic life events accumulate, compounding symptom expression and severity. This suggests trauma prevention and early intervention may be an important target for decreasing the incidence of psychotic disorders and ameliorating its effects. Psychiatric disorder. From a diagnostic standpoint, organic disorders were believed to be caused by physical illness affecting the brain, that is, psychiatric disorders secondary to other conditions, while functional disorders were considered disorders of the functioning of the mind in the absence of physical disorders, that is, primary psychological or psychiatric disorders. Subtle physical abnormalities have been found in illnesses traditionally considered functional, such as schizophrenia. The DSM-4-TR avoids the functional/organic distinction and instead lists traditional psychotic illnesses, psychosis due to general medical conditions, and substance-induced psychosis. Primary psychiatric causes of psychosis include the following: schizophrenia and schizophreniform disorder affective, mood disorders, including major depression and severe depression or mania in bipolar disorder, manic depression. People experiencing a psychotic episode in the context of depression may experience persecutory or self-blaming delusions or hallucinations, while people experiencing a psychotic episode in the context of mania may form grandiose delusions. Schizoaffective disorder, involving symptoms of both schizophrenia and mood disorders, brief psychotic disorder, or acute/transient psychotic disorder. Delusional disorder, persistent delusional disorder. Chronic hallucinatory psychosis. Psychotic symptoms may also be seen in schizotypal personality disorder, certain personality disorders at times of stress, including paranoid personality disorder, schizoid personality disorder, and borderline personality disorder. Major depressive disorder in its severe form, although it is possible and more likely to have severe depression without psychosis. Bipolar disorder in the manic and mixed episodes of bipolar I disorder, and depressive episodes of both bipolar I and bipolar II. However, it is possible to experience such states without psychotic symptoms. Post-traumatic stress disorder, induced delusional disorder, sometimes an obsessive-compulsive disorder, juvenile onset affective disorder, dissociative disorders due to many overlapping symptoms. Careful differential diagnosis includes especially dissociative identity disorder. Stress is known to contribute and trigger psychotic states. A history of psychologically traumatic events and the recent experience of a stressful event can both contribute to the development of psychosis. Short-lived psychosis triggered by stress is known as brief reactive psychosis, and patients may spontaneously recover normal functioning within 2 weeks. In some rare cases, individuals may remain in a state of full-blown psychosis for many years, or perhaps have attenuated psychotic symptoms, such as low-intensity hallucinations, present at most times. Neuroticism is an independent predictor of the development of psychosis. Man, of all the things I've been commissioned to say, this sure is one of them. These long-ass words.